Hello, my name is Braden Saba, and it's a real honor to be presenting to you today. Thank you to all the previous presenters and the presenters to come for their compelling work and great discussion. My name is Braden Saba, and I'm currently a fourth-year medical student at the Wake Forest University School of Medicine in Winston-Salem, North Carolina, in the United States. I'm grateful and honored to have the opportunity to speak to you all today. Today's topic comes from a project that I led with the help of an amazing team of collaborators in the Department of Ophthalmology at Wake Forest. Special thanks to lead PI, Dr. Adelie Thompson, for her leadership and guidance on this project. I have no disclosures to report that are relevant to this study, nor do any other members of the team. The inspiration for our study arises from the observation that falls are highly prevalent among both eye patients and the elderly. Both groups are vulnerable to the severe consequences of falls, yet the exact relationship between ophthalmologic disease and fall risk remains relatively underexplored. As you can see here, falls are extremely costly on the American healthcare system, as well as morbid and mortal, with 36 million annual falls in the United States costing $50 billion in expenditures. For reference, that $50 billion expenditure is nearly identical to that of COPD. Based on our curiosity in the relationship between vision and falls, we chose to study a patient population that experienced an acute change in their vision. While there are many sources of acute vision change, most notably stroke, trauma, infection, vasculitis, retinal detachment, and more, we chose a case population of patients who experienced a disease state known as Anterior Ischemic Optic Neuropathy. We were grateful that our paper entitled Relationship of Visual Function with Incident Fall and Mortality Among Patients with Anterior Ischemic Optic Neuropathy was published to the Journal of Clinical and Translational Ophthalmology this February. Before discussing the study in detail, we should begin by describing the case group, as AION, or Anterior Ischemic Optic Neuropathy, is a relatively rare diagnosis, but serves as an effective surrogate for disorders resulting in visual field deficits as a whole. AION is an ischemic event of the anterior portion of the optic nerve, as seen in the AION zone on the left side of the image pictured, which causes sudden and severe vision loss and visual field constriction. This event is permanent, sudden, and quite often presents upon waking from sleep. Some mechanisms such as nocturnal hypotension have been proposed for this, but it is not yet definitive. This condition also rarely presents in individuals under 50, with a median age of onset in the early 60s. It also shares many of the established risk factors for falls, such as age, hypertension, diabetes, hyperlipidemia, arteriosclerosis, nocturnal hypotension, and obstructive sleep apnea. Here, I've demonstrated what an AION defect can look like to the patient. In this case, this would be a right eye medial defect causing a right lateral visual field defect. It's important to clarify that this disease does not cause strokes to the visual cortex of the brain. Thus, the unaffected eye should be still entirely functional. However, the extremes of vision are particularly susceptible to visual field cuts due to the lack of redundancy. A central field defect is also quite possible and presents significant challenges for the patient. An inferior defect is also quite possible, which, particularly in an elderly patient with significant ocular and systemic comorbidities, can result in serious potential for falls and subsequent injury. Now that we've defined our case group, let's move on to our materials and methods. This was a single-center retrospective cohort study where all patients with a new diagnosis of AION within a 5-year window were identified. No patients under 18 were included. Any patient who had ever been diagnosed with glaucoma was excluded, as this can cause fluctuating changes in vision over time and obscure the relationship we were interested in. Data collection was EMR chart review based with significant manual confirmation and meticulous data acquisition. A priori confounding risk factors were also obtained by a careful review of patient notes, history, problem lists and medications and included the following: hypertension, diabetes, any diagnosis consistent with dementia, like Alzheimer's, frontotemporal dementia, etc., cardiovascular disease, for example, history of MI, CHF, CAD, cardiothoracic surgery, PAD, congenital heart malformations, AFib, or other arrhythmia, cerebrovascular disease like stroke, and polypharmacy, which we defined as taking 5 or more systemic non-ophthalmologic medications. Also, the presence of other common age-related eye conditions were also noted, which included cataracts, diabetic retinopathy, age-related macular degeneration, and others. These were included in our analysis as well. Statistical analysis was performed with separate bivariate Cox proportional hazards models. We used 2 means of quantifying the visual impairment present. One was a +1 unit increase in the log-Mar scale, a scale that is similar to the visual acuity metric that we're familiar with, like 20/20, 20/30, etc. Our other metric was a binary variable of legal blindness or not, characterized by 20/200 or worse in the worse affected eye. The patient population included in this study totaled an N of 428, with the mean age of 68.1, 40% of which were female, 7.2% of which were non-white. The most prevalent comorbidities in the cohort were polypharmacy, of which 83% of patients had, hypertension at 65%, and cataracts at 47%. Now that we've described our case group, let's move on to our results. I think they're pretty interesting. Shown here are the unadjusted and adjusted associations of visual acuity function with risk of fall, mortality, and a composite outcome among patients with AION. So let's break that down a little bit. So on the left of those 2 columns, you see the unadjusted models. Those are pure associations between the independent variable, which is log-Mar visual acuity or legal blindness, and the likelihood of falls, which is in the top row, mortality in the middle row, or composite risk, which is the combination of the 2 based on time, in the bottom row. And then on the right, we see the adjusted models. In this case, we adjusted for all the covariates listed to try to isolate the association between vision and the outcomes. So that right column is the adjusted models, and the left column is the unadjusted. The center dot in the middle of each line is the hazard ratio, and the 95% confidence interval is the black line that extends laterally from it. As you can see, in every case, except for the unadjusted models in the fall risk top left corner, there's statistical significance to a positive hazard ratio across the board. This supports the theory that worse vision causes more falls and mortality in nearly all ways described, like I said, to a pretty statistically significant degree in most cases. Shown here is the raw data results, in which you can see the majority of p-values are comfortably below 0.05. Additionally, of interest, the strongest hazard ratio of the entire set can be seen in the legal blindness group for incident mortality when adjusted for covariates. That hazard ratio is shown by the arrow, and that is 2.16 with a p-value of 0.004. Of note as well, all composite analyses showed a statistically significant increase in the hazard of an adverse event in patients with a +1 log-Mar unit or with legal blindness, which, similar to as I mentioned on the previous slide, suggests that just about every way you slice it, there's an increased propensity for falls, mortality, and composite risk to a statistically significant degree. And even in the models where there isn't statistical significance, it's close, suggesting that this association is a strong one. So far, we've shown a lot of raw data and talked a lot about the design of the study, but I think the implications are why we really are most interested in this conversation. It's a very specific case group. It's a very rare diagnosis. And so I think the generalizability of it was always on my mind as a researcher in this project. It's always important for me to be able to extend any finding to a greater clinical picture, a greater clinical context that sort of guides management. That was a big priority of mine, just feeling like it was something that meant something. It wasn't just looking for an association in the data set. And I think that that is what we sort of unpack in the discussion and conclusion. So a few of the takeaways from the study. Just in general, worse visual acuity, particularly legal blindness, was associated with a greater risk of falls and mortality. We saw that demonstrated by the increased hazard ratios, and it's a relatively intuitive association. You'd think that somebody who has a worse vision is more likely to trip and fall. We as people are very reliant on our sense of sight when we ambulate, and the lack of sight can be a big risk factor for falls. Additionally, while slight differences were observed between the unadjusted and adjusted models, it wasn't all that substantial, which really surprised us. But that does suggest that the poor vision is likely more of an independent risk factor for the adverse events described. So it looks like when you adjust, not a lot changes, suggesting that the vision is driving that increased hazard ratio more than we might have thought in the first place. Additionally, in our literature review, we found that prior studies found associations between poor vision and falls, but there were significant limitations to these studies. Many of them used self-reporting assays or patient surveys, phone calls, things like that, cross-sectional design, and lack of control for significant risk factors. So no study attempted to sort of tackle all three of those in the way that we did. And there were some studies in the past that even showed an unconvincing association between poor vision and fall risk, which surprised us. The Salisbury Eye study is a multi-year, very sort of powerful study that was prospective cohort and sort of was published in 2007. And the findings of this showed that there was some slight increased risk, but very minimal, and certainly nothing substantial like we've seen. Another interesting topic of discussion is that our chosen mechanism of visual impairment for this study, our case group of AION, is the only sudden onset visual impairment specifically studied with respect to these adverse outcomes. So there are no studies to our literature review of acute onset visual impairment, such as retinal detachment or trauma or infection, the things we stated before, and how they related to falls and mortality. So we thought it would be particularly compelling to study an acute onset of vision loss, because that might be more representative of a vulnerable patient population, especially as these patients often wake up from sleep without their vision, with a significant chunk of their vision missing, which can of course be alarming but difficult to adapt to immediately. A case group like glaucoma has multiple years of degeneration, and so it's very difficult to see the effect of their visual impairment on their function because they have time to adapt, they have guidance, they have time to use the internet, use their clinicians, talk to their friends, sort of get physical therapy. All the things that help avoid falls are things that they have time to work with. Whereas in this acute onset vision loss group, we figure that when you lose your vision, your life changes immediately, but you might not, especially as a person in the geriatric population, you might not have the tools to be able to adapt to that. And that's significant. Additional considerations through our study, we also found that other factors contributed to the increased fall and mortality risk, including age, non-white race, and cardiovascular disease. In order to further characterize these, though, further explorations would be required. So to put that in other words, we found that those independent risk factors outside of the vision loss itself seem to show increased risk for falls and mortality. There are studies that we cited in our paper that show those associations in the past as well. And so they have been documented, but they haven't been characterized super thoroughly. And so that's something that could be considered in the future. Additionally, of interest, Polypharmacy, which is something we think of as a real contributor to cognitive impairment and just systemic dysfunction in older adults, was not, in our case, an independent risk factor for falls and mortality, at least not to a statistically significant extent. And then dementia showed a positive association with falls, but was equivocal for mortality. So it wasn't as convincing as we might expect, thinking of dementia as a significant risk factor for mortality. So like any study, there are strengths and there are also weaknesses, and so we wanted to be transparent about those. Some limitations of our study: it is a single center retrospective cohort study, and so the sample size, while 428 was a great number for us, it is limited, and a larger sample size would of course increase the power of the study. Falls did not necessarily result in a healthcare visit at every occurrence, and so oftentimes patients may fall at home and not come into the clinician, or when they do, they mention it in passing, but they've fallen enough that the clinician doesn't document it as a new fall, or for whatever reason, falls are probably very underreported given our methods. We did our absolute best to catch every fall we could in the system, but more than likely falls are occurring a lot more frequently than we were able to catch. And then additionally, AION is a diagnosis that requires an ophthalmologist, and so if somebody presents to the emergency department for the first time having an episode of vision loss, they won't get tagged with AION until well after, during their outpatient ophthalmology follow-up, but they may have fallen already. And so there's this discrepancy, there's this window of time in which a patient may have fallen but not be diagnosed yet, and they would not have fallen within our study criteria. The strengths of this study: there was significant labor put into the data collection and the review for all patients involved. Almost every data point in our spreadsheet was manually acquired, which was really based on wanting the most accurate data, but also some of the ophthalmologic data sets are a little bit trickier to mine through an automated fashion. And so using our team and our workhorses, that's how we got that done. And then significant a priori risk factor controlling was performed, which is very unique to our study. It's very rare to get as much control as we were able to do to create the unadjusted and adjusted models as we did. So let's move on to the conclusions. Thank you for your attention thus far, and let's talk about how this study can be clinically relevant for your patients. In conclusion, poor vision leads to poor outcomes, and we've demonstrated that in this study. This study shows that both falls and mortality are more likely in patients with visual impairment of the AION variety at our center. Additionally, there are no evidence-based treatments that can restore lost vision from AION. It's a permanent disease, for the time being at least. And so in order to best help these patients, we can't help them surgically or with a medication that's going to give them their vision back. And so we have to help them with lifestyle modifications. And in order to best characterize those and best find the most effective lifestyle modifications, and education and multidisciplinary team approach, further studies would be required to evaluate the effectiveness of various therapies. Various therapies could include an education-based approach, a physical therapy-based approach, and some sort of visual rehab, or something completely different entirely. Additionally, it's important not to ignore that many of the systemic comorbidities that caused potentially the AION in the first place also contribute to falls. And so controlling those systemic comorbidities could be extremely high yield in terms of improving these patients' outcomes and reducing their mortality. In the meantime, I would urge you as providers, if your patient has any acute onset vision loss, first of all, refer them to ophthalmology, potentially urgently if it's a new onset vision loss. But then also, it's important to have a discussion or consider a discussion about fall risk and the ways to avoid these adverse events that we've seen can be morbid and mortal. Thank you all very, very much for your time, your patience, your listening, and I hope that with this conversation we can reduce adverse events and improve the lives of our aging population. Thank you.